Hello, dear students and esteemed learners. Welcome again. Welcome to my course on Sociology of Health. This is lecture number 44, and in this lecture, we'll talk about maternal health in India, the interstate disparity. We have been talking about the reproductive health, health of women, and maternal health, and also pregnancy care. And till now, we have understood how basically we look at these things and what is the importance and significance of maternal health and reproductive health, and what kind of approaches basically are emerging at global level, and how Indian government has responded to that, and what are the some of the achievements also. So we have understood this much. However, in the previous lecture, we also stated that despite the achievements, we can see that the states of India are not having these similar kinds of outcome. That means one state is performing much better and another state is performing not like that. So there are important issues related to the inequalities prevailing in terms of the states, which are generally identified as the interstate disparities. Now, not only at the level of the state, but there are disparities prevailing in the rural and urban levels. Now, three things are very important here. Let me talk about that. One is this, that health in India is largely an issue related with the state. So, although we have seen that there are specific interventions by the central government or the union government, but the execution or implementation of health related issues are a matter which are basically handled by the state. And when we look at it from the public health perspective, then of course by the urban local self-government organizations. So primarily in the day-to-day functioning and in making the improvement, the required improvements and the interventions, the state governments have the larger say. The central government, of course, provide the policies and monitor and regulate the thing at the larger level. So when the state has the larger responsibility, and if the disparities are existing at the level of the states, that means the states are not performing very well. And it would be very important to know what is the health outcome in various states. Because unless we know that, we will not be in a position to make the right kind of intervention. Now, there are specific terms to understand the differences in the health outcome, and the word health inequity is generally used for that. So there are inequalities as well as inequities, but inequalities are generally used for the context where the things are more structural or structured. So we talk about caste inequality because caste is basically a kind of structural thing. However, when there are gap or differences or inequalities existing in the domains where these could have been changed by making the right kind of intervention, then these are basically identified as inequities, right? So there is a prevalence of health inequity, and these gaps are identified, and these are primarily understood as the disparities. So with this brief understanding, we will try to understand the important disparities in terms of the outcome of maternal health in Indian context. And we will also try to see the gaps, the rural urban. Sometimes the disparities are also identified as gaps, right? So these are various terms we will try to see, And in this lecture, I have covered many points uh, that you will see, but I have included the Declaration of Astana also, and then the concept of empowered action group EAG states, and I have briefly talked about NFHS 4 also, because we have taken the data from NFHS 4 survey, and then we have talked about the some of the important concepts on the basis of which we have tried to understand the disparities. So we will see all these things. Let's go to the first slide. And here we will talk about, we'll try disparity and the problems of accessibility. So why this problem of disparity is existing wherever it is existing? So there are multiple factors. Of course, there are issues related to political governance, then administration, then of course the fund and resources, and then the organizational structure also, and also the socio-cultural and economic environment, because health care needs budget and funds. And we had seen in one of the previous lectures that the states do not allocate the same proportion of the budget to take care of the health needs of the people. So when where there is the allocation is high, the performance can be better, and where the allocation is much lower, then the burden of taking care basically goes on the people, and that is something that we try to understand by making use of the term out of pocket expenditure. So there are financial aspects, there are political aspects, then there are socio-cultural aspects also, right? So there are two important things. One is the Declaration of Astana, and this declaration very categorically talks about the prevalence of the inequities and disparities. So let us go through one of the statements that was given by Dr. Tedros Adhanom, who was the Director General of the World Health Organization, right? So what does Dr. Tedros say? Dr. Tedros is saying that today, instead of health for all, we have health for some. So although we had the Alma Ata Declaration way back in 1978, and that time we talked about health for all, but unfortunately the goal of health for all has not been achieved, right? And this Astana Declaration, that is also conducted on the primary health care, on which the Alma Ata Declaration was made after 40 years of Alma Ata, that is making an assessment of the situation, and then it is saying that the situation is not that good. Then let me quote another important person. Basically, instead of talking about person, let me quote the declaration itself, part of the declaration, right? And part of the declaration says that it is unacceptable that inequity in health and disparity in health outcomes persist, right? So I have included this so that you get an idea that at the level of the global summit, which is participated by all world countries, right, and which was held in 2018, that is very recently, there is an increasing realization that inequity in health is prevailing, and disparities are existing among the countries and within the countries. So we will try to understand, but at the global level, these disparities are actually not appreciated, and the global bodies basically remind the nation state to take care of the mechanism through which those disparities could be and should be reduced. Now, there is a very important concept of empowered action group states of India, right? We need to talk about this because time and again we will find information related to that. So, 8 states of India, which are Rajasthan, Uttar Pradesh, Uttarakhand, Bihar, Jharkhand, Madhya Pradesh, Chhattisgarh, and Odisha are called Empowered Action Group states. These 8 states lag behind in the demographic transition and have the highest infant mortality rates in the country. So they are lagging behind, they have high infant mortality, and now when there is prevalence of high infant mortality, then there is the prevalence of high birth rate also, because if the mortality is not controlled, then as per the demographic transition theory, the fertility will also increase, right? So 8 states have been identified and they are designated as empowered action group states, so that special care should be taken for these states. Now, what does the statistics talk about these 8 states? I mentioned these things very briefly here. So, comprehensively or in totality, these 8 states contribute for 50% of India's population. So, there are 29 states and other union territories, but these 8 states basically make the 50% of the population. And very disproportionately, basically 68% of the childbirth. So the fertility rate is very high, and that is why basically 68% of the childbirth or the births basically are taking place where 50% of the population is residing. You can see, you can compare that. And very unfortunately, 70% of the infant deaths are also taking place. That means the fertility is high, the birth rate is high, and at the same time the death rate is also high. And that is why we are saying that these states have not undergone the demographic transition. And out of the 70% infant deaths, 72% of the under 5 mortality is also prevailing in these states, and further 80% of the maternal mortality are also prevailing. So now we can identify the concentration of maternal mortality cases in the geography of India, right? That here are these 8 states where maximum of 80% of maternal mortality cases are prevailing. So if you want to reduce maternal mortality, we need to take very important steps, very meaningful interventions in these 8 states which are identified as empowered action group states. So with this understanding, basically, we will proceed further. Now, the data that I have used in this lecture is primarily taken from the National Family Health Survey, and this National Family Health Survey is providing most authentic data on the population health and nutrition related issues of India. And basically there are series of NFHS data. We had the NFHS first, second, third and fourth, and now the fifth is also available, but still the comprehensive details are not available there. And so basically we have to rely on NFHS 4, which was conducted for the years 15 and 16 and which got published in the year 2017, and it provides us very in-depth information about several important things. And then I have also added here that the NFHS is basically using a very robust design and sampling method that is mentioned over here. But we don't need to talk about it, but just added this information so that you may have a look on this. Now, we'll talk about the BMI. And so let us have a very precise understanding on body mass index also. Body mass index is an anthropometric measure relating weight to height, equal to body weight in terms of kilogram divided by height in terms of meter squared, right? So it is like that weight of the person divided by height and basically height squared, right? So if you know someone, basically say X person is there and X person's weight is known, then X person's height is also known, then you can calculate the body mass index The only requirement here is this, that the weight should be expressed in kilogram and the height should be expressed in meters. Of course, this can be converted, right, in appropriate other units also, but what we follow here or in India generally is the kilogram and meter. Now, what does it indicate? That is very important basically. A cutoff point of 18.5 is used to define thinness or acute undernutrition. So, if someone is having BMI less than 18.5, then that person will be identified as thin or undernourished. And a BMI of 25 or above indicates overweight or obesity. And when someone is having a BMI of more than 25, then that person will be identified as fat or obese or overweight. That means the range between 18.5 and 25 is basically more acceptable. However, if you take the average of these two numbers, then you can reach closer to the prescribed. These numbers, of course, are not universal. In terms of gender, it will vary. In terms of the specific age, it should vary. And as of today, we are not having the the gender specific BMI and age specific BMI. So this needs lots of improvement, but it gives you a very general understanding about the undernutrition, basically the underweight people, and of course for the overweight people, because those who are suffering from obesity are basically one can get information about that, and those who are suffering from undernutrition, one can get information about that, right? So with this, we move to the empirical data collected by NFHS, and here you can see the bar diagrams, and here I've used basically multiple things. You can see that the NFHS 4 figure is here, and then NFHS 3 figure is also here. So a comparison could be made between the NFHS 3 and NFHS 4. Then figures for good number of states are here. Basically the states which are performing better and the states which are lagging behind. However, I have included the larger states because some of the smaller states do have some extreme values, but that is actually not telling the larger story, because smaller states have their own advantages in terms of administration, right? And then very important figure is related to the rural and urban gaps or disparities, right? So there are valuable information in each of these slides. It will not be possible for me to talk about everything, but you can have a look on each of these slides and extract the kind of information that you are interested in, right? A broader pattern we can try to understand, and basically that is the purpose of including these things, so that we get a broader understanding about the overall pattern which is prevailing. Someone who is interested in knowing the specific state can focus on that. And then of course the NFHS 4 data is available in the public domain in the websites of the Government of India and the relevant ministry. And then you can have a look to those figures there only if you want further details. And I would like to add here that the specific information about the states are also included in those NFHS data, right? So whatever information you want, if that is available there, then you can get it, and that will give you great insight. So with this, basically, let us try to understand what is mentioned here. So percentage prevalence of women whose body mass index is below normal, that is BMI is less than 18.5 kg per meter square. So 18.5 up to 18.5 is considered normal, as we understood in the previous slide. And there are women whose BMI is less than that. So they are actually considered as malnourished, in terms of BMI. So what is the percentage prevalence of that type of women? We happen to see that in Jharkhand, the prevalence is high among all these states. Basically, if we see the NFHS 4 figure, which is basically highlighted in green, then you can see that as among these states, it is highest in Jharkhand, followed by Bihar, then Madhya Pradesh, then Gujarat, then Rajasthan, Chhattisgarh, etc. And if we want to see the better performing states, then we can see that the Sikkim, Mizoram, Kerala, Punjab, these are the better performing states. These are also having percentage of women whose BMI is below normal, but that percentage is actually much lesser than the national average. So almost all states have this category of people, but some states have huge number. So those are actually having more problems, and then some states have lesser number. They are performing better than the rest. All states of India have witnessed improvement in BMI between NFHS 3 and NFHS 4. Now, this is the silver lining, that because we have data for NFHS 3 and 4, so we can make a comparison, and we find that there is a improvement between NFHS 3 and 4, and this is also getting reflected at the national level. But the huge disparity between rural and urban areas in percentage prevalence of BMI in many states like Jharkhand. Now, in Jharkhand, see, the prevalence rate is much lower in the urban areas, that is 21.6. And this is very high in rural area, that is 35.4. So the rural-urban disparity is actually very problematic, because one particular state is getting governed by one government, one political party. So the budget, allocation, all those things are actually similar within the state. And if there is such a gap or disparity existing within the state between the rural and the urban, then this story tells about the development of that particular state and the kind of vulnerability and marginalization which is existing in the rural areas. And if this nutrition related indicator is showing such a poor performance of the rural people, then the performance will get further problematic in the other areas, basically, which are related to healthcare services. So these are some of the valuable input that we are getting from these things. And then you can see that a state like Gujarat is also having the rural-urban disparity. Rajasthan is also having rural-urban disparity, and Uttar Pradesh is also having. So there is a huge disparity. That means the states which are performing poorly because of the problem existing in the rural areas, right? We can get this kind of trend, because the states which are performing better, there the gap between the rural and urban is much lesser, and the states which are performing poor, then there the gap between rural and urban is much high. So we get this kind of understanding from these figures. Then pregnant women age 15 to 49 years who are anemic. Now we have been talking about anemia. Anemia is basically the shortage of the RBCs and in the blood, and that is basically causing multiple type of deficiency in the body. That is at the root cause of different types of ailment and problem, right? So at a more general level, we say that in India, the prevalence of anemia is very high. More than 50% of the women are basically anemic across the various age groups. That is a kind of general statement that we used to give. But here we will see the figures. So at what is happening basically at all India level, right? So the green bar is basically showing the NFHS 4 figures, and let us go to India and see that this is 50. That means very truly in India, 50% of the women coming under the reproductive span, primarily the 15 to 49 years, are actually anemic. This is very serious. Now, even the better performing states like Kerala or Sikkim or Mizoram are having this prevalence more than 20. That means when we talk about a state like Kerala, which is considered as a model, right, in terms of healthcare among the Indian states, even there, this prevalence of anemia is around 20% as per this NFHS 4 figures. That is in itself very challenging. Some of the states with a low proportion of pregnant women who are anemic are Kerala, Sikkim, Mizoram, etc. On the other hand, Jharkhand is the worst performing state, having the highest percentage, that is 62.6% of the pregnant women who are anemic, followed by Bihar, then Haryana, Madhya Pradesh, Tripura, and West Bengal. So, these states are the states where the BMI is less than the average. Then these are the states where women are more anemic. Now, these two conditions actually give you an idea that the overall health condition of women and then the health condition during pregnancy and then the health condition of the infants or the neonatals is going to be very poor, because these two are major indicators which actually indicate the level of nutrition. And if the level of nutrition is itself compromised, then the rest of the problems are just waiting to occur over, waiting to inflict those people. Then, if you make a comparison between the reports of NFHS 3 and 4, we find that the percentage of women aged 15 to 49 years who are anemic increase in three states, which are Delhi, Himachal Pradesh, and Punjab. Now, that is also happening, that this percentage is also increasing. That means anemia is a very contemporary issue. It's not related with the income level, because these states are actually the economically good performing states. So it's more about the social practices, the cultural practices, the health awareness, and several other social indicators. Then states with highest and lowest percentage institutional birth. Now, we were talking about basically the proportion of birth attended in the presence of trained health personnel. So, when we want to ensure that the birth should take place in the presence of trained health personnel, then that kind of birth should take place within certain healthcare institution, right? So, this healthcare institution is not necessarily tertiary grade or a secondary grade hospital. It can be a primary health care center or a designated center where those deliveries can take place, where some kind of facilities are there. So, the community health centers are basically the designated places. However, because of the availability of the health personnel and the paramedical staff, some of the other centers also play the role of being a good place for giving birth. The primary health centers are not primarily meant for that. But at the level of the sub centers, we have the ANM and we have the ASHA basically, who are connected with the village people. So, what is important here is this, that some sort of connection or some sort of connect or supervision with some of the institutions should be there. Now, that can be a government facility, government hospital, or that can be a private facility or a private hospital, right? But there should be a proper arrangement to take care of the needs related to childbirth, and so that if required, the mother as well as the newborn baby can get these kind of services. So that is what is basically institutional birth. Now, some states are performing very well, like Kerala is having 99.9% institutional delivery, Tamil Nadu 99%, right? Whereas there are states which are not performing well, again, like Bihar, Nagaland, and other states are visible. Uttar Pradesh is also like one state. Although there are some progress made very recently, but that is not getting reflected in these figures. I hope that you will be in a position to see the detailed information when the NFHS 5 figures will be available, right? So you can keep on updating yourself on these. Then one very important thing here that I have added is the prevalence of cesarean section delivery. Because when we talk about institutional delivery, then within the institution, basically the normal deliveries do take place and the cesarean section deliveries also take place. Because when there is some kind of medical complication in the normal delivery, then the doctors do prescribe the cesarean section delivery, and this is generally known as the cesarean section delivery, right, where some kind of surgical operations do take place. And we can see in this slide that there is a twofold increase in the prevalence of cesarean section delivery from 8.5% in 2005-6 to 17.2% in 2015-16. So the proportion of the cesarean section delivery is increasing, and some of the states where this prevalence is higher is basically Andhra Pradesh, then Kerala, then Jammu and Kashmir, Tamil Nadu, and Goa, etc. Whereas there are states where this prevalence is much lower. So we can see that in Telangana or Bihar or Chhattisgarh, this is very low. Then birth in a private health facility delivered by cesarean section. So basically there are the public facility like the government hospitals, and then there are the private hospitals also. So is there any gap between the public sector hospital and the private sector hospital in terms of prevalence of cesarean section delivery? So those basically questions could be answered by having a view on these slides, because these specifically talk about these. The percentage of birth in a private health facility delivered by cesarean section has increased from 27.7% to 40.9% at all India level. That means there is a huge jump. Among all the institutional deliveries, the specific deliveries where the cesarean section is actually taking place, if we talk about that, then we see that there is a huge jump when we look at it in the private hospitals, and that is actually talking about one more trend, that in the private hospitals the cesarean section deliveries are increasing. Now, to what extent that is medically justifiable for answering this question, I have added one small statement here, but we have some published work on that also. And according to WHO, there can be prevalence rate up to 15% in any society for medical complications or medical reasons. That means if the cesarean section delivery rate is prevailing up to 15%, then that may be because of the medical reasons in any society. So if the prevalence is more than 15%, then there may be involvement of the non-medical factors, and there can be basically good number of other reasons. Time will not allow us to talk about these things, but if you are interested, then you can find out good number of research paper on that. And I also have a paper basically, so you can trace that. That is related to the prevalence of cesarean section delivery, and authored by me and a co-author Nadia Muzaffar. So if interested, you can find it out, and that was published in Economic and Political Weekly. Then there are few other things like states with highest and lowest percentage birth in a public health facility delivered by cesarean section. So basically here we are talking about the public health facility, and you can see that the figures are quite different from the kind of things which were there in the private hospitals. And then average out-of-pocket expenditure per delivery in a public institution. This is a new data that was provided by NFHS 4. There is an extra data made available in NFHS 4, which is basically related to the out-of-pocket expenditure per delivery in public institutions. And according to this figure, the average out-of-pocket expenditure at all India level is rupees 3,198, and it varies from state to state, ranging from 1,387 rupees in Madhya Pradesh to as high as 10,076 in Manipur. So basically these numbers keep on changing. The point that I would like to mention here is this, that there is a cost basically, and that cost is basically that cost is addressed by the people, and that is generally known as the out of pocket expenditure. And when these deliveries take place in the public hospital and the private hospital, then there is a huge gap. We will try to understand that when we will talk about the privatization of health and universal health coverage related topics. But I just wanted to highlight that there is a situation. Then there is an arrangement of financial assistance under the Janani Suraksha Yojana. The highest percentage of mothers who received the financial assistance under Janani Suraksha Yojana for birth in an institution belong to Odisha, then followed by Chhattisgarh, Assam, and Madhya Pradesh. So these are the other kind of support that the state is basically providing to address the kind of cost that people are having. So there are situations which are not very good for certain states, because these are witnessing different types of disparities. And Government of India basically had launched a new program in 2013 that is known as the RMNCH plus A, and that is basically reproductive, maternal, newborn, child health plus adolescent, and it tries to address the problem caused by those disparities, because it has identified 184 high priority districts. So there is an area specific approach which is there. We'll talk about this in the next lecture. So I hope this lecture helped you to understand not only the prevalence in different states, but also the disparity which is existing and the disparity that needs to be addressed, and that is why a new approach has developed, right? So have a look on this, think about this, an activity question, and then we will meet in the next lecture. Until then, take care.